Top of the morning to everyone. Thank you so much for joining us today for this session, this first session on the first day of this amazing conference. I hope everyone is having a fabulous morning. We're gonna jump in and get started. And thank you for your patience for those of you who waited. My name is Carlene Valentine, and I'm one of the co-leaders of the Health, Equity, and Social Determinants of Health work group. Um, Slide is not, okay, here we go. So our session today is going to entail an introduction of our work group, our goals, our mission statement, who the work group leaders are. We're going to review a brief history of health equity. We're going to have some health equity principles described. And we're going to touch on engaging people with lived experience. And we have an amazing guest speaker and subject matter expert who's going to join us as well. So we're looking forward to this very much. Okay, so our objectives are to introduce the Health Equity and Social Determinants of Health work group, our mission and goals, and our work group is accepting new members. So we're hoping that some folks will find this session very interesting and join us so that we can collectively continue to work on these goals as a group. We're going to recognize a brief historical foundation, review some principles, and at the end, we're really hoping to walk away with some ideas and brainstorming for action items, like what we can do in real time in our local regions. And I will pass it off to Haley.
Thank you. Good morning, everybody. So our mission statement for the Health Equity and Social Determinants of Health work group is to foster collective knowledge and plan strategies for applying a social and structural determinants of health approach, ensuring health equity for all. To apply strength-based perspectives for learning from community health disparities issues, to monitor the evolving changes in the social determinants of health landscape and the impact on health equity for all, particularly underserved and marginalized populations, and to focus on evidence-based community participatory research techniques for engagement in data collection, measurement, and outcomes evaluations.
Hello, everybody. So I'm going to talk about the goals real quick. So one of our main goals is developing a developing a resource for just social determinants of healthcare, developing something that is a guideline that really focuses on equity. And obviously, it's very important to continue networking and getting a lot of reports out, and then, of course, bringing things back to our local resources and finding ways to empower our community as well as to uplift all the voices around us, especially those of lived experience and marginalized populations. And then, of course, encouraging not just local, but all of our organizations to engage communities, especially at the very beginning stages. That way, we have people lived experience every step of the way, telling us what matters and what's most important for them.
Okay, so I will formally begin our introductions. As I said, Mike, Haley, and I are the work group leaders for this particular work group, and I'll be introducing Mike Gutierrez, who identifies as Mexican, a Mexican agent of change. His gender pronouns are he, him, his, él, and lo. Mike has over a decade in healthcare and social services as an HIV STI tester counselor, a crisis intervention specialist, medical education and prevention advocate, a facilitator for an abuse intervention program, and most recently, Mike was a program manager for a Ryan White Part D program at Howard Brown Health. He created and co-chaired for Howard Brown's Latinx committee, and Max Gaiman of Color Fellowship, and was a research lead on NSTAD's bilingual bicultural care team pilot protocol. Mike is passionate about working with the LGBTQ community, survivors of sexual assault and domestic violence, and the Latinx community. Through community organization and advocacy, Mike's goal is to incite change and give a voice to the marginalized communities that we dedicate ourselves to helping.
And then I will be introducing Haley. Haley earned a master's in science from Johns Hopkins University and has over a decade in urban public health while focusing on behavioral health, adolescent reproductive health, infectious disease, food access, health equity, and currently oversees grants and external funded programs, as well as the administration for the Ryan White federal funding and a regional hospital system based in Baltimore, Maryland, and has served as a subject matter expert in adolescent behavioral and reproductive health.
Thank you. And then last but not least, we have Carlene Valentine. She, her, Aya. Carlene has worked over a decade in public health, focusing on community-based HIV prevention strategies, HIV treatment, care, and supportive services. She currently serves as the operations manager for an ambulatory HIV program, primary care and supportive services Ryan White funded program at a large New York-based health system, serving 10 federally qualified health centers. She also serves as the project director and co-principal investigator for 3 grant-funded HIV prevention programs funded by HRSA, CDC, and the New York State Department of Health. She has a passion for social justice and positive social change.
Thank you, Haley and Mike. Okay, we're gonna kick it off to Mike. You're on mute, Mike.
All right. Just so everyone knows, I do have 2 screens, so if you see me moving around, that is why. Just a quick disclaimer. So real quick, just talking about health equity. This is a concept that originated from the disciplines of public health, sociology, and political economics, and has been a major research in the area of special opinion since the 19th century. Health equity, according to WHO, emphasizes that all individuals should have the same chance to reach their highest potential in terms of health, along with that no individual should be prevented from performing at their highest potential. And then just a lovely visual that we have here that talks about the differences between equality and equity. And one thing we really want to highlight is just being mindful that people who have different abilities, they're not always visible. And because of that, we really want to make sure that we're being very intentional every step of the way. Some of you may have noticed we had closed captions on, and that's also something that's really important because if you look, and this is something to think about, especially when coming thinking about people with different abilities, we do have people who may be hard of hearing or just have hearing at a different level. And that's also a great example because that's not something you can physically see in the moment unless there's some type of interaction going on.
Thank you, Mike. Before jumping to the next section, I see that we have a hand up. Did you want to share or ask a question? PHP Hospital? Maybe there's in the chat. All great event. Okay. Levis Medical Laboratory. Thanks for joining us. Okay, so we're just going to review a brief history. Before we know where we're going, it's important to know where we've been, right? So it's a very brief history on research around health equity, which has been, both formative and informal, developmental, and expansive, mostly between 91 and 2018. Okay, so in 1946 was the first time we saw endorsement by the World Health Organization around the idea of health equity. In 1966 was the first time we saw a publication where health equity was recognized, although they say it is traced back to 1801. In the 2000s, we had lots of action. We have the National Center on Minority Health and Health Disparities that was established. We have Health and Human Services release of the first Healthy People document, which was 2010. And the Office of Minority Health releases national standards for cultural and linguistically appropriate services in healthcare, also in 2000, which was a major turn for positivity in the area of health equity. And HHS releases now Healthy People 2010, 2020, and we now have the most recent iteration, Healthy People 2030, which is to say the intention is to continuously have this ongoing goal, set of goals, national goals. In 2016, we saw Section 1557 of the Affordable Care Act on non-discrimination in health programs and activities. So it's a major step towards acknowledging that discrimination does occur. And HRSA publishes a health equity report, which is a comprehensive analysis of program efforts in reducing health disparities and promoting health equity. Another major win. And in 2021, the Office of Minority Health and the CDC launched the Minority Health Social Vulnerability Index. And the purpose is to enhance existing resources to support the identification of racial and ethnic minority communities at greatest risk for disproportionate impact and adverse outcomes. And this came about due to the COVID-19 pandemics, which really brought these disparities to the forefront.
Thanks, Carlene. And I'll be introducing our subject matter expert for this morning. Dr. Stella Saffo is the founder and CEO of Just Equity for Health. She is a board-certified HIV primary care physician, a public health advocate. She is an assistant professor and strategic advisor, dedicated to equity within healthcare. She is a founding member of several organizations dedicated to gender and racial equity. She was named one of modern healthcare's top minority clinicians to watch. She is a current New York Academy of Medicine Fellow. She has a medical degree from Harvard Medical School and a public health master's. She's a primary care and social medicine practitioner at Montefiore Medical Center in the Bronx, followed by an HIV fellowship from the HIV Medicine Association. She currently serves as the social medicine curriculum director and an adjunct assistant professor of medicine at Montefiore Medical Center. She also consults for projects around equitable care model design and has a commitment to social justice work. She provides care to patients in New York. She has been featured in various academic and popular media, including CNN and MSNBC.
And now we'll kick it off to Dr. Stella Saffo.
Awesome. Good morning, everyone. Thank you so much for being here. And thank you to the organizers for inviting me in. I'm looking forward to speaking today a little bit about where we are when we talk about and think about health equity, and what we need to be considering moving forward. I think you've seen the agenda, and there's a report really is open for discussion. So as I share my comments, my hope is that you will start to really frame for yourself how you can think about applying this in this new world order that we are all entering. Next slide. So my background is as a clinician, as a healthcare systems designer, and as a healthcare user. And as a clinician, I've worked with HIV, with patients who are living with HIV and other chronic medical conditions. I was interested in ethnic differences. So it is clear that the healthcare system works for certain individuals, really impacted the work that I do as a health systems design practitioner. We design healthcare for individuals. And in that role, if you can go back to the previous slide, in that role, what we have for individuals to be able to have the best healthcare that they need. And so I think a lot about, what are the elements that have to go into place? And you'll hear me talk a little bit about how we do health equity-based design using certain frameworks. And then finally, as a healthcare user, as someone who has a chronic medical condition who's in and out of the hospital, what is always interesting to me is the ways in which I am treated and approached when I just, enter the healthcare system as a youngish looking Black woman versus when people know that I am a member of the health system or I'm a physician or a public health practitioner. It shouldn't be that you need these fancy degrees to get the treatment that you need, and yet we know that that is the case. And so with these kind of perspectives, next slide, I want to talk to you today about a couple of different areas that I think we have to explore. This is for us to really consider where we know that we're facing backlash and we know that the ways in which people are thinking about health equity is a zero-sum game, that some people get something, other people don't get something. And so there's a real pushback against it. And I think we have to be honest about what that means. Next slide. Next slide. So we'll start talking about some of the kind of foundations around health equity. And I think that some of it has been introduced of healthcare delivery. So if you think about things like healthcare outcomes, healthcare access, certain disease states, and you just pick one characteristic, there's many characteristics you can pick. You can pick gender, geography, sexual orientation, but if you pick what I picked here, which is race and ethnicity, and you take a look at the differences by race and ethnicity, you can see that individuals experience differences in disease outcomes, in insurance status, in access to life-saving therapeutics like mental health services, and in what we in public health consider kind of indicators of good public health, which are infant deaths and maternal health outcomes. And you can see how that differs across the different racial and ethnic groups. And we know in healthcare and we know in medicine that these differences are not because of a biological propensity, for example, towards diabetes, or a biological propensity for, Black babies to die more than white babies. We know that it's something else that's at play that's leading to all of this. Next slide. And one of the ways I would say that we really had this proven is what we saw when we experienced COVID and Mpox and other brand new pathogens. So Mpox is a disease that we had never seen in the Western Hemisphere. When it entered in summer 2022, we saw something really interesting happen right away, which is that although Black people made up about 13% of the population, somehow they accounted for over 27% of new Mpox cases. Similar for Latinos as well. And then, one of the things that we always think about is if individuals are the ones who are being the most affected by a disease, they should end up being kind of the first to get vaccines and other therapeutics for the disease. And that isn't what we saw. In the bottom graph on the left, we saw that Black people, Latino folks were actually the lowest to be vaccinated when vaccines were made available for Mpox, which really reflects, again, some of the societal realities. And then going over to COVID, COVID was a brand new pathogen in 2020. No one had ever seen it before. And I want to give you the example of what happened in New York City. So New York City has 5 boroughs, and in those 5 boroughs, the city Department of Health broke them down by zip code. And they looked at the cases of COVID. And so the purple areas are the areas with more COVID. And what is so interesting is that the areas with more COVID, and I just used 2 examples, one of them is Manhattan, and the second one is Brownsville, Brooklyn. Those 2 areas already had an 11-year life expectancy difference. If you sat on the train from Brownsville, Brooklyn, and you went all the way up to Manhattan, which is about a 40-minute train ride, your life expectancy would increase by 11 years. That was before COVID, that was before anything else had happened. And that kind of foundation was then reflected in how COVID cases hit those neighborhoods, because the individuals who lived in Brownsville and Brooklyn were much more likely to be infected by COVID. You can see the darker purple there. And they were much more likely to actually have poor outcomes once they were infected in terms of morbidity and mortality from COVID infections. So again, if you didn't kind of believe me when I talk about chronic conditions and, like diabetes or public health indicators like infant deaths, when you look at this slide, what you're seeing here is an indicator that if you bring a brand new pathogen, a brand new infection that no one has ever seen, and you spread it into the United States community, you will see that different racial and ethnic groups have a differential impact by these pathogens, right? Even though our biology is the same. So there has to be some way to explain it. And that's when we start to talk about the issues around social drivers of health, political drivers of health, and ultimately around health equity. What this all led to is that by the end of really 2021, 2022, when we're looking at life expectancy, everyone's life expectancy fell about a year and a half. Black people's life expectancy fell 3 years. American Indian and Alaskan Natives, their life expectancies fell by 6.6 years. We'd all experienced the same pathogens, the same kind of infections, and yet different groups had a major different impact on life expectancy from this time period. Next slide. And so where that kind of brings us is to really start to talk within clinical medicine about what we understand about biases and how they play into clinical medicine. We've been talking about health equity a lot, I would say, in the last 5 to 7 years. But even before this, there was some language that was used in clinical care delivery. There's a very famous book called Unequal Treatment from the Institute of Medicine that came out in the early 2000s that really identified that something was happening in medicine where, people who deliver medicine, doctors, nurses, tech and other staff are like the general public, and they probably have some of the same biases that people in the general public have. And we started to use the language in the early 2000s of implicit bias and the way that implicit bias plays into care delivery. And you're going to see a little green term sign located next to some of the terms that I'm going to bring up that I think are really important to really be able to talk about health equity and some of the things involved in it. And so implicit bias was one of the many forms of discrimination that take place without really being aware of it interpersonally. And I'll talk about certain other forms as well. And the reason why I'm bringing this up is that early studies show that implicit bias that clinicians may have had against their patients by disability status, sexuality status, race status, actually impacted the way that patients experienced care. So you can see different outcomes for those who are treated for heart attacks, cancer care, and pain treatment. And it isn't surprising that implicit bias is the reason why certain groups actually reported different patient satisfaction, different desire to use health services because of the ways that they were then treated. So what I'm saying with this slide is that we have had language for this and we've understood this for many, many years. And now that we're kind of talking about health equity, which is fantastic, it's important for us to know that we're building on a foundation that has been set. Next slide. And so what is that foundation? How did we kind of get to this point where we're naming, social drivers and health equity? Well, it's important for us to also kind of name what social drivers of health are. And some people will use the term social drivers of health. Some people will say social determinants of health. They are more or less interchangeable, but I will tell you that there's a slight preference for social drivers because it's more action focused. It shows that there is something that's causing these differences to take place. And what are these? There are 5 kind of categories that we count under them. You can see them in the graphic to the left. It's things like economic access and stability, education, healthcare access, neighborhood and built environments. So for example, do you have groceries with healthy foods? Do you have sidewalks where you can walk? And then social and community context. How much of your population has been incarcerated? What is the impact of gun violence on your population, et cetera, et cetera. And all of those things we know are the non-biomedical ways in which people's health are then impacted. And we've been talking about it more and more because of a couple of realities. One, in 2020, COVID-19 did shift society a little bit to say, again, all of us are getting COVID, but some of us are dying more. What's going on? And that language of social drivers and health equity really came up. The other reason we're talking about all of this more is because of population health. Many of you in your health systems and in different areas are in a system now where you're going to be paid by how well you keep a population. You're not going to be paid by how often someone gets sick and comes into the emergency room or is hospitalized, right? And so population health says that we have to focus on prevention and wellness. You can't really focus on prevention if you're not thinking about some of the things that make people sick, like lack of access to healthcare, or like lack of access to safe spaces to exercise and get good food. And then finally, we're talking about all of this now because this is really expensive. Social drivers of health are responsible for tremendous excess costs, up to $320 billion, $20 billion annually, according to a study by McKinsey. Next slide. So this all kind of brings us to a place where we have to kind of acknowledge some key terms. And I think it's been described here, but I'll kind of describe it for you again. Now, the term health equity really describes a state that we want to get to, that it's achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving that potential because of their social position. And again, if you look at this definition, what it's saying is that there is a place that we all want to get to. And it's acknowledging that some of us are prevented from getting to that place because of what is said here is social position or other socially determined circumstances. So health equity isn't static. It says something is going on that's impacting the health of individuals, and we have to acknowledge what that something is. There's another kind of term to be aware of here, which is equity versus disparities. We often use them interchangeably, but I will note here that disparities just describes the differences in outcomes, whereas an equity really talks about, again, that social cause, the societal cause that's led to those differences. And just like how we say societal drivers or equity, we're really trying to put action into this so it doesn't feel like, oh, that's just the way it is. Black people die more from diabetes. That's just the way it is. No, there's an action and a reason why that is the case. And we have to always, always focus on that. Next slide. And I would say that it's important as we talk about health equity and we talk about some of the reasons that we've gotten to kind of social drivers to think about what some of the underlying causes are. And some of these causes are things that all of you are very familiar with. It's things like structural racism that's built into the very legal structures that impact individuals. Things like classism, sexism, capitalism, work exploitation. And, you know, part of the reason why I think this is important to really name is that if you want to really think about addressing the societal causes that lead to unequal health, you can't do that if you don't name the things that are causing them. And we're not saying here that somehow all of us sitting in this virtual room have to go and solve racism, but we have to be willing to call it out as the cause of some of the things that we're seeing that then drives and impacts individuals' health. Next slide. And I think that this is all because we're thinking about this larger picture of health justice, right? We don't just want to talk about the differences between health outcomes for individuals, which is what disparity does, or just talk about equity, which, you know, talks about the societal causes, right? We actually want to be focused ultimately on a concept that I think we don't talk about nearly enough, which is health justice. And health justice calls for us to do something to actually change the societal causes that have gotten us to the point that we are. And this to me is one of the takeaways I hope you all kind of walk away from this conversation with, which is that health equity work, it's iterative. You build on it, you build on it, you build on it, right? You don't just do it and you're like, okay, we're done. You continue to kind of address the reasons why, you know, you have to have an equity lens. And it's a journey, right? So rather than arriving somewhere, you're kind of on this road to really be able to get to where you need to get to improve society for all. Next slide. Two other steps, and I'll give you an example of what it looks like to apply health equity lens to the work. So one concept is to think about root cause analysis. And so if you look over here where it says health outcomes, which is in the purple lettering in the graphic, you know, health outcomes are things like, you know, Black moms have worse maternal health outcomes than white moms, right? And if you take one step up to really understand that, you start to talk about social drivers or social determinants of health, which is this may be happening because they have less access to transportation to get to appointments or less health insurance to make sure that they're able to get the right kind of health care that they need. But if you go up one level up, then you're talking about why is it that, you know, Black individuals have less access to the economic strength that they need to be able to protect their health, right? You're talking about then economic investments or disinvestments. You're talking about policies. You're talking about societal realities like redlining, things that have led to the realities that then lead to the social drivers that then lead to the health outcomes. And so kind of thinking about these kind of structural determinants is a real framework that we all have to consistently come to, especially in medicine. We've talked a little bit about cultural competency as, you know, the way forward. I would say it's really that we need to focus on structural competency instead. Next. And I think a final concept that we have to hold is the ways in which multiple identities play. And so this concept of intersectionality is one the key term. And it says that individuals or communities can hold, and that can be across sexuality, gender, geography, and the ways in which this plays into creating the unique experience. Community living in the Bronx, New York may have a different set of health challenges than a community coming from South Carolina. And so a one size kind of, you know, approach to all of these communities is often the reason why some of these blanketed outreach programs can tend to not work. It's because we forget the reality and the importance of keeping an intersectional lens as we do the work that we do. So kind of in summary of this first section, next slide, you know, we're really talking about understanding where we've gotten to slide before, where we've gotten to with thinking about the different levels of inequities. And I would kind of encourage all of you, we tend to talk about implicit bias or interpersonal inequities, but I would encourage all of you to go one level kind of further up, which is institutional bias, right? And so these are the forms of discrimination that an institution may inadvertently or on purpose have that impacts health outcomes. For example, legislation that prevents, that medically segregates institutions, that is a bias that is at the institutional organizational level. Or institutions that don't have language services, that is a kind of bias that's kind of put forward by the organization. And then the kind of highest level we want to get to is what I spoke to you about with structural inequities, which is around the kind of bias that society implements. And so, for example, legislation that restricts gay marriage or legislation that restricts abortion rights. What is tempting for us to do as people who are interested in improving kind of outcomes for our populations is to focus just on the interpersonal, because in some ways you can control that, right? You can ask doctors and healthcare workers to train in implicit bias training and get over their biases. But we have to really question what's happening around the institutional biases and around the structural biases that we can also impact. Next slide. So I would say that a health equity approach makes us think about structural inequities. It has us use an intersectional lens. It often asks us to design solutions with those who are most impacted. And it really forces us to think about the different levels on which an inequity might be happening. And this is particularly important, I would say, in healthcare. I really like this quote from Dr. Martin Luther King Jr., who says, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. I would say that if individuals don't have their best health, they can't do anything. They can't achieve their educational potential, their artistic potential, their generational potential. And so what we are kind of sitting at and talking about is so foundational to the well-being of individuals' lives that we have to be really intentional about how we do this work. Next slide. And so this lecture isn't to really focus on the how, but I will offer two examples of how you can use a health equity lens. The one on the left is called DEVS. It's from my company, Just Equity for Health. The one on the right is called the Healing Arc. It's created by Doctors Morse and Wispelry, who have used it in multiple national contexts. And I'll describe the one on the right in more detail. And basically what a health equity framework does is that for any project that you're doing, it forces you to ask a couple of questions, to be really intentional about the approach that you're taking. And so, for example, in the work that I do, I'll think about who's at the table designing this health equity work. I'll think about what environment it is that we're using. I'll think about the value of how we're measuring success and what we're taking into account in terms of, what we consider to be important and what we measure. And then I'll think about a very kind of strategic approach to scaling. And I'm not going to go into it in more detail just for the sake of time. Next slide. I think a health equity framework that can be applied today is the Healing Arc framework. It's a really excellent framework, and it basically has three parts to it, which says when you're facing a healthcare challenge, you need an acknowledgement portion about the ways in which health inequities are playing into it. You need a redress portion, and then you need a closure portion. So I'll give you the example of how this was used. In Boston, in the Brigham and Women's Hospital, data kind of led to the reality that Black heart failure patients were dying at a higher rate than white heart failure patients. And when they kind of looked at the root causes of this, they found that Black patients were not being referred to the heart failure service as often as white patients. It wasn't clear exactly why, but it was what was happening. The heart failure service at Brigham and Women's Hospital is one of the best in the world. If you can make it there and you have heart failure, you will probably do pretty well. If you can't make it there, then obviously you won't do quite as well. So they first acknowledged that there was this inequity and this difference. They invited community members in and they said, what can we do to help to address this? And the redress portion of this is community members saying, well, we would like to be first up. We'd like to be chosen and prioritized to be able to utilize this service. So that's what they did. They had emergency, had the internal doctors who were taking care of the floor, have a say, does this patient who has heart failure, would they benefit from being sent over to service? And then they went back and they asked the community members, is this being done right? Is this kind of appropriate? Does this answer what we needed to answer? So it was used and it worked so well that white just felt offended, that white people weren't naturally kind of being prioritized in their care, and they marched on the Brigham and targeted these two doctors who were leading it. It was also used to do clinical algorithms that include and we won't talk about it, but that's a really interesting area that I think is at the forefront of addressing health inequities. It was used to prioritize vaccines in COVID. You know, I talked to you about how certain groups are dying more of certain infections. Those groups should probably be first or prioritized when it comes to getting vaccines. And so this Healing Arc framework was used to really think about vaccine rollout in Michigan and in New York. So this is an example of the ways in which we can move from just talking about the terms that I've introduced to really applying it to frameworks that individuals today can use in how they're designing healthcare delivery for populations that have been historically marginalized. Next slide. So in this next area, I will just kind of talk to you a little bit about what's happening as it relates to where we should be aware of and where we're going now when it comes to challenges towards a health equity approach. And I think it's a really, apt time for us to have this conversation, just given the kind of, I would say, historical time that we're in. I think we're going to reach a time where if 2020 was a moment where people were really interested in talking about health equity and health inequities and how we could address them, I would say 2024 is a time where we're going to see a lot of backlash. Part of that backlash is due to the healthcare worker challenge. We are seeing 1 in 5 healthcare workers leaving their practice over the next 2 years. That's what's been projected. We are expecting a healthcare shortage, particularly of primary care workers, of about 50,000 by 2034. And this is all compounded by the administrative burden among physicians, as well as burnout. And with the reversal of affirmative action, the growing lack of diversity of the workforce. It is already the case. It takes too long to see primary care doctors, which is really hard in rural areas and in areas where there isn't that much access. It's only going to get worse. And the reason why we're talking about this as an equity issue is because we know in areas where there are, a high Medicaid population, the doctors who tend to take them tend to be Hispanic and Black healthcare workers who are willing to be the ones who actually go and see these patients, these Medicaid patients. Medicaid patients tend to be more likely to be from racial and ethnic minoritized groups. And so it matters if we're talking about a healthcare worker shortage. It matters if we're talking about less diversification of the healthcare workforce. We know that the groups that are already at higher risk for poor health are going to be deeply impacted by this. Next slide. The other reality and the other challenge that we're seeing is really being able to measure health equity metrics. So right now, CMS has required all health systems to measure social determinants of health, which is great. But social determinants of health are just a proxy to really understand the societal factors that are driving health inequities, right? Because we talked about how health inequities are really coming up when you think about societal inequalities. So how do you measure those societal inequalities? And there's some effort to really try to capture that, but I will say that it's imperfect. And so, again, we're using health disparities, like in health inequality and outcomes as a proxy. We're using SDOH as a proxy. But there's new measures, which I didn't include here, so you can just disregard where it says below. There's new measures like structural drivers and community determinants that groups like Robert Wood Johnson are trying to create for us to be more precise about how we really measure health equity, the phenomenon of health inequities within care delivery. And I would just encourage you to keep your eyes and ears open for that, because I think it's going to end up being an area that really develops quickly. Next slide. And then I'm going to end, and then, we'll open it up to discussion. So please feel free to think about your questions, continue to include your questions and comments. And then I'll turn it back over to your hosts to really kind of facilitate a discussion for us. But I'm just going to kind of end in talking about 3 realities that we're facing that's making this work harder. The first reality is a cultural backlash. And so over the last couple of years, we've watched that terms like critical race theory, woke, have become really bastardized. And what is so interesting about this is that most of the folks who are coming after these terms don't know what they mean, right? And often the way these terms are used are really, I would say, an anti-fill in the blank. People say woke when they mean anti-trans. People say woke when they mean anti-Black. And it's a more accepted way to be able to say these things. In fact, when you drill down, 7 out of 10 people don't know what critical race theory means. And yet 29 states have legislation that restricts it completely. What's really at play here is a desire to not teach history, which is what a lot of critical race theory is trying to do, is trying to teach about the kind of racialized realities of legal theory and history. And what's at play here is to try to silence people who are speaking up about inequities by branding them this term, is a really interesting one. And then 1940s, Black individuals who were seeing what was happening in the South and throughout the US, say, aware of what's happening in your circumstances. And so it was a real time of Black empowerment. And to see it kind of now be done in the way that it is unfortunate. There's a call for us to think about how we reaffirm and retake some of these terms and how we don't participate ourselves in loosely using them in a way that continues, that I think discourages people from calling out inequities where they see it. And then in all of this, you know, as the culture rising and emboldened kind of white supremacy realities. Again, asked for Black people to get better healthcare. This last weekend, Nazi in Columbus, Ohio, with absolutely no challenge to their being in the streets because of the environment that we're in, where people feel really emboldened to spread this kind of hate. Next slide. We've often believed that our institutions would be the place that will protect us or will help us. And I will just kind of share with you the kind of realities of what's happening in workplaces, especially healthcare institutions that have purported to really support diversity, equity, and inclusion efforts and health equity efforts. Since COVID, the financial structures and backings of a lot of healthcare institutions have been challenged. Many of them are relying on, you know, state or federal funding. And as state and federal funding turns against you know, the kind of focus on health equity, many of these institutions are going to be closing their doors around this as well. But even institutions that are not in healthcare, you know, corporations, you can see that some of the DEI efforts and investments that were spoken of in 2020 have really started to fail. Part of it is that leadership hasn't been sustained. The other has been that teams that have been hired to come in and work on DEI have since then been either whittled down or fired. And the DEI strategic kind of focus areas in a lot of these areas have been so narrowed and not part of the overall strategic plan of the company that it's easy to sideline them. So this is kind of just to say that our institutions are not going to be the ones to really lead the way, it seems, around health equity efforts, which is really unfortunate. Next slide. And then finally, when it comes to the political landscape. And so the political landscape is one that's really interesting because I've talked to you all about kind of the cultural changes that we're seeing, the institutional changes. You can kind of think about this as like the structural changes. It is happening more and more that there's growing legislation targeting equity-based principles for certain groups, right? Whether it's the reversal of affirmative action, whether it's anti-trans legislation, whether it's the restrictions of teaching about certain, you know, realities for certain populations, like, you know, the impact of racism and impacting Black health. All of these legislation, all this legislation that was kind of trickling down the last 4 years will probably be codified and hardened in the upcoming 4 years with the new administration. And so there's a real question for those of us who are sitting here today of like, how will you show up? How will you resist? How will you protect these populations? You know, when I am in clinic since the election, I've had folks who are coming in who are living with HIV who have said, doc, like, should I expect to continue to get my HIV medicines? Or people who have said, you know, as a trans person, I'm really afraid I won't be able to get my hormones. And, you know, we live in New York, we live in New York City. And so our hope is that as a quote unquote blue state, we'll be able to continue to provide services and protections to individuals, but it isn't totally clear what's going to happen in the political landscape. And I think all of us have to prepare ahead to meet the moment. I don't think you can meet the moment if you're bearing. And so with that in mind, let's kind of wrap it up for discussion. Next slide. As I wrap, I would just kind of leave you with a couple of thoughts and then kind of a question for you to consider for yourself, which is, you know, we know that health equity is where we want to be. It's the goal that we have started off speaking about. And while it's challenging to get there, it remains the kind of end point of the journey that we're on. And I would say that the need for health equity lens to really improve health outcomes for historically marginalized populations is something that we have been talking about for decades. And I'm glad that we're talking about it even more now. We have clear language around why it's so important now. The steps that we have to take to be able to really incorporate it into the way that we do public health work and clinical work, I think is still very kind of developing, right? And so there's examples like the Healing Arc framework that I gave you, but there's so much more that's needed, like being able to measure health inequities and really have institutional support for all of this. I would say, though, that we're in a time where we're going to be facing more challenges than less, right? And we're going to need to think about solutions that are going to offer protections to the groups that are most at risk. And these groups are the groups that have already been kind of the most marginalized and will likely be marginalized going forward. And so the question of how we proceed and what we do to offer protection is really up to us. And I would just name that a lot of times when we talk about health inequities and the work that's needed, we often look to individuals who are in those marginalized groups to do the saving. And for many of us, after the results of this last election, many of us want a moment of rest and respite to kind of collect ourselves as we think about the future fight ahead. And I want to encourage that because I think that rest is actually very strategic if you think about, what may be needed to kind of meet the moment that's coming for us. But I think that this is the question: how do we proceed in a time where challenges to health equity and really equitable care are coming at us? How do we use our various forms of privilege, whether it's privilege in education, privilege in skin color, privilege in location, to be able to offer those protections? And with that, I'm going to leave you with a quote, next slide, from Desmond Tutu, which is something that I've been trying to kind of really dig into, which is to have hope in these times. That hope is being able to see that there is light despite all of the darkness. And I think that we are probably heading into a dark time. But my hope is that we will be able to be part of the realities that lead to some lightness. And with that, I'm complete. Thank you so much for your time. And I'm opening it up for discussion. Turning it back to you, Carlene.
Thank you so much, Dr. Sappho. That was an amazing presentation. And I would love to open the conversation up so our attendees, with any feedback, input, ideas on what we can do at our own local levels to kind of promote implementing a health equity lens in the work that we do, or even on a grander scale. So please feel free to unmute yourselves or put something in the chat. I'm glad to read it. But we would love to hear from folks. See if there's anything in the chat.
It looks like Marcelo has raised their hand, so you want to mute or write in the chat box?
Yeah, I am muted. I think that we should not expect for a white hero to come and save us. That whatever change we want to have has to start with us and be increased as much as possible by coalition work.
I really agree with that. I think that there will be no institutions, politicians, etc., that will necessarily be able to reverse some of what's coming. I think it's going to be important for us to think about the ways in which we can really stand 10 toes down in protecting the health of the populations that we know are going to be the most targeted. So I think that's quite right.
And there's a question in the chat from Carla. It says, what do you think we should do if the worst happens? Federal legislation hinders the work.
I think that there's conversations that we can have with our institutions now. One of the things that was so interesting, before the Dobbs decision came down where Roe v. Wade was reversed, there were some institutions who started to prepare ahead of time for the reality that abortion rights could be taken. So there's a really great article, I'll see if I can find it at some point, that talks about one hospital system in Ohio that prepared and one hospital system in Tennessee that didn't prepare. And essentially what the hospital system that prepared did is they met and they said, these are the worst case scenarios that will happen if Dobbs, goes into place and Roe v. Wade is reversed. This is the legal protection that we think we will need. This is how we want our staff to behave, et cetera, et cetera. And yep, Roe was reversed and they put their plans into place. Part of the reason why they could is because they weren't panicked, right? They had kind of set the scenario ahead of time. And they'd also said, this is what matters to us. This is what's kind of we want to invest in. And the health system that hadn't done that preparation ahead of time ended up not being able to get it together after the fact because they were in the reality of Roe being reversed. They were so scared of what would happen to them that they just kind of never really got the right folks together to make plans. And so to me, that's kind of a great example of, you plan for the worst, you plan ahead of time. I would say there are conversations that need to happen now, that would say we're asking our leadership, request a town hall and point blank, ask your CEO, if we are told that we need to report the names of illegal immigrants, that come to our health system, what is our action? And get them to kind of verify and, go on record saying we are not going to be participating in that. And here's how we're going to avoid that, right? I'm just giving that as one example. But I think it's important to do that now when folks are not living in a cycle of fear than it is like 3 or 6 or 9 months down the line when it's just one point of bad news after another. And there is no sense of kind of collective coming together for that preparation.
Julia has her hand up.
Well, hi, thank you, Dr. Safa. That was an amazing presentation. I'm from the New York City Department of Health, and it really, whatever you said, what you said about health equity really made a lot of sense to me. I think sometimes people, as you said, don't understand the term, and they've heard it so much. I think there's a little bit of, fatigue around the term, but you really made
Yeah.
it kind of come alive again. But I wanted to ask more a question about like our political landscape and your opinion on it. So I feel like, over the last couple of years with all the laws being passed about reproductive health and other things around the country, that New York is kind of, a bastion of, you know, um, safety and for a lot of people coming to New York or traveling to New York. But I think that that also comes with a lot of burnout, and we have limited resources in some ways. And I guess
Mm-hmm.
I just wanted to ask your opinion on whether how you feel like we can kind of help strengthen systems in other states, and be like not only just set an example, but just kind of help them to strengthen their systems. Because we know that in New York, as you said, we're pretty lucky, we're pretty protected. But how
Yeah.
do we communicate that and not get burned out at the same time?
Yeah. And I'm sorry the whole time I didn't realize I didn't have my face on here. So hello, everyone. Um, I think that there's a couple and you're asking such a good question because no one state, no one area is going to be able to handle what's coming, you know? Um, One of the things that I'm always impressed by, and maybe it's just because we went through this recent election, is that all of these areas that we're talking about, red states, blue states, however you want to use them, they all have like some parts of the state that are more blue, if you will. And we know that they all have individuals within that state that are individuals that maybe have more progressive ideas. I think moving forward, we're going to have to be really willing to share our knowledge, Um, it makes me think a little bit of kind of like just indigenous ways of kind of moving forward where, by word of mouth and by kind of coming together and collective teaching, you expand your impact. And so one of the things that, a couple of us have been working on is understanding how to do baseline abortion care, right? It isn't part of what I do, but like, is it something that we can learn that we can then teach to other folks who are in these areas that can do medication abortions? Similarly, I think there's really interesting work happening around some of the public health interventions that haven't historically been paid for. But I think one of the things we're going to see in this new age is a lot more mutual aid. And so if, pockets of areas that want to kind of offer themselves self-protection are paying for, can get resources, how do we teach them about, wastewater surveillance or other things that may be helpful to be able to kind of have that area be safe? What I think is disturbing about all of this and what makes it hard for me is that we know that networks protect networks. And so if you your family networks in certain areas and you can kind of get them resources and get them information, they'll probably use that, right? But if you're talking about communities that have been historically disinterested in, who's going to be looking for them? So like for me, one of the things that I did post on day is I just really very serious commitment to myself that I'm going to be really intentional about naming that I'm looking after Black communities, right? That I'm really invested in helping with the health of Black communities because I no longer think it's just good to say BIPOC or people of color. I think we have to name, who it is that we're looking after. And I think we have to name it at times because we know that those are the communities that may not get the mutual aid going to be able to offer themselves safe distilled water when the water's, supplies have been damaged, right? And so who among us is kind of, tagging ourselves to say, those are the ones I'm going to go make sure that they're okay. Those are the ones I'm going to go make sure they have access to abortion services, et cetera. So that's a very long answer, but I want to offer that because I think it's important for us to be really honest that, what the first gentleman said, no one is coming to save us. We are very much on our own in this time. And it will only be our networks and our kind of collective abilities that will move us forward. If we do not acknowledge that reality, I think we will be sorely, sorely disappointed. Um, um, and we'll just waste time being upset when I think like the time to be upset is probably now to process. But like when things start to really hit the fan and things start to really happen, we don't have time to be sad that our local elected officials aren't standing up or our institutions, have capitulated or whatever it is. We have to be thinking, what are we doing to help individuals now? So my kind of short answer is from your place within public health, I would really think about what's a sister public health agency that could use your help and your insight. How do you mentor? How are you a peer, mentor to them to really help them through a time that's going to be tough?
Thank you very much, Dr. Sapp.
Any other questions or comments? Chat. This has been a wonderful engagement. I'm so glad to hear from folks in the audience, the great questions. There's lots of work done and so much more work to be done. I really hope folks would consider joining our work group. One of the things, I think I put it in the chat, but one of the things we really would like to do is kind of pull from all of these places. This is an international conference, so we have members from Africa, from the States, and kind of pull together, resources may not apply from what we have available in the United States to what we have available in other countries, but to know what is out there, what people are doing, what is working, what isn't working, and to kind of learn from each other and just build and grow and support each other. I think, as Dr. Sappho said, it's not easy work. It is challenging to kind of shake the table and trust these systems. But we have to do it. No one is going to save us. So if we can be a resource to each other and support each other in this work, it I think can really help us stay positive, stay focused, and just keep fighting the good fight. So I really hope folks would consider joining us. We have a preliminary work group schedule. Um, we can skip over these. We were going to go into a little bit about engaging people with lived experience and kind of dive into co-designing for programming, but I think we'll pull that into our January work group session for 2025. I did want to leave folks with this health equity as an ethical principle. It's a human rights issue, right? I think it's really at the root of why we're fighting this good fight. So I did want to leave folks with that. I know we're over time. I so appreciate everyone still being on. Feel free to drop your emails in the chat. I'm gonna add mine, and Haley and Mike will add theirs, and I will stay on until I get everyone's email address before I log off. But this has been wonderful. I think it's a very much needed ongoing conversation I would love to continue with folks. Thank you everyone so much. Oh, that's a
Thank you,
visual.
everyone. Take care.
Thank you.
Write these emails down because they are coming in fast.
Hello, good morning. I had a question.
Sure.
Um, are you able to join the group if you're not a medical professional? I'm a sickle cell advocate.
Yep.
Absolutely.
Okay. Oh,
Anybody can join. We welcome anybody.
oh,
I am not a
oh,
clinician myself, so we definitely have space for everybody, and we welcome everybody's opinions.
okay. Thank you so much. I
Mhm.
really enjoyed this session.
Great, thank you for attending.
Thank you. Haley, can you maybe do screenshots of the chat in case I misspell any emails? I would hate to not be able to reach out to folks, because
Yeah.
I skipped the letter.
I'm
So
also copying the email addresses as well.
say it again, Mike.
That I'm also copying the email addresses as well.
Oh,
Like
perfect.
copying and pasting them. Yeah, I'm sending them in an email to both
Oh,
of you.
great. So we can cross check. Fantastic.
It looks like we still got about 47 people on.
Yeah, so hopefully, folks will be interested in joining. This is our remaining schedule for 24, and then these are our projected 2025 work group meeting dates. Please note the times are Eastern time zone. That has been a little bit of a challenge for us, but we did try our very best to find times and dates that work best for folks, for all of our international partners. And it looks like Mondays at 1:30 have been the most successful days of the weekend time of the day so far. So we're gonna stick to what has worked. But we're definitely flexible and able to move it around as needed. So if it doesn't work for you, please let us know and we'll do our best. We also have an online platform that we share information, meeting minutes, and resources, workshops, things like that with our work group. So if folks join the work group, you'll get access to that IO platform and you'll be able to access information. So if you should miss a meeting, you'll find the meeting notes there, and you can share information there as well. So I just wanted to put that out there, that we have more than one way. Of course, we communicate by Zoom meetings, by email, and we use that platform. So we try to utilize all the tools we have at our disposal to reach everyone the best way that works for them.
Thank you, everyone.
Thank you, Crawford, for your call. Appreciate it.
Yeah, no problem. They have another session starting at 11:15. If you want to join, um, if not, we will end this session.
Thank you very much. Thank you.
Thank you.
Are we able to stay on this link, or do we have to create a new link?
I'm not sure if other sessions are using the same links. I'm trying to rush to get all these emails down. But I'm pretty sure we recorded it. We should be able to have access to the recording.
I meant more so for us to talk and check in.
Okay, I think I have all the emails.